Good day, everyone. Hi, I hope you're all
Hi.
doing well. All right. On behalf of the Gifted Gabber Research Program, I would like to welcome our research students, our parents, and of course, our distinguished research professors. A special acknowledgement goes to our esteemed research professor, Professor Prahlad, and of course, Professor K. Diaz for their invaluable guidance and expertise in shaping the research studies of our students. So, today marks a very important milestone in our students' academic journey because this academic exercise does not only showcase their hard work and dedication, but also their ability to think critically, present clearly, and engage meaningfully. Of course, with the guidance and the feedback from our creative writer and research professor. So, I'd like to give the floor to Professor Palad to give the welcome remarks to our students before we proceed with the presentation.
Hi, students. Welcome to the final presentation of the 2025 summer session. You guys can all pat on your back. You've done excellent job so far, and we look forward to your presentations today. Let's start then.
Thank you, Professor Prahlad. All
Yes.
right, now let's move forward. We will now proceed with the research presentation. So each student, will be given 10 to 15 minutes to present their work. And I'd like to request everyone that after the presentation, you need to ask one question for each presenter in the chat box. Okay? So we'll now proceed with the first presenter. Our first presenter is Tanishi. Tanishi. Okay, I think Tanishi is not around. Um, Akil. Is Akil here?
Yes.
Okay.
um,
All right. So I'd like to remind again our research students to open your camera during the presentation, okay? All right. Akil, can you start presenting?
okay.
Okay, so after Akil, we'll have Myra, and it will be followed by Satvik, then Rishikesh, then Rohan, Tizia, and Arav. And the last presenter will be Pranav. Okay, so are you ready, Akil?
I'm trying to share. I'm kind of having technical difficulties. 1 second. Can you
Okay,
see my screen?
yeah, we
Oh,
can see your screen now.
just
Um,
one.
you can move your slide.
Oh, okay. Okay. All right.
Okay, Akil, can we adjust your cam so that we can
Yeah.
see you properly?
Uh,
That's better.
all right. So, 1 second. Um, okay. All right. I'm ready. Hi, my name is Akil, and wait, did my presentation go away? Can you guys see my presentation?
Yeah, we can see your
Okay.
screen.
All right. Hi, my name is Akil, and this is my presentation on CRISPR gene editing and CAR T cell therapy for glioblastoma. So, my research topic was the effects of CAR T cell therapy and CRISPR on glioblastoma. Glioblastoma is a type of brain cancer. The goals of my research paper is to summarize existing knowledge, highlight gaps, and propose future directions. What is glioma? Glioma is the most aggressive type of brain cancer. Most aggressive type of brain cancer. The goal, GBM or glioblastoma usually starts in the glial cells. Glial cells are supportive cells that protect nerve cells in the brain and spinal cord. Why glioma is such a severe condition? GBM affects critical brain functions such as memory, movement, and speech, making them life-altering even when treated. Although GBM only affects 6 out of every 100,000 people, they're often difficult to cure because their tendency to grow quickly and they resist current treatments very well. Need for better treatment options. The median survival is generally about 12 to 16 months after diagnosis. When patients get the stop regimen, or which is surgery, radiotherapy, and temozolomide chemotherapy, the survival rate for 5 years is only around 5 to 7%. Newer cures like CAR T cell therapy, which are still in the experimental stage, can completely change how long a person can survive. Key questions. So some of the key questions are, what is CAR T cell therapy? CAR T cell therapy is where a patient's T cells are engineered to recognize and attack cancer cells. What does CAR T cell therapy stand for? CAR T cell therapy stands for chimeric antigen receptor T cell therapy. How does CAR T cell therapy work? T cells are collected and modified with a CAR receptor, multiplied and reinfused to destroy tumor cells. What types of cancers is CAR T cell therapy used for? Right now, it's approved for blood cancers like all blood cancers like BL, BCL, multiple myeloma, and mantle cell lymphoma. Research is still ongoing in solid tumors. Some of the main benefits of CAR T cell therapy, it can induce long-lasting remissions in otherwise treatment-resistant cancers. The risks and side effects right now for CAR T cell therapy is cytokine release syndrome and neurotoxicity, which can be life-threatening. Why is CAR T therapy not widely available yet? High costs and complex production and the need for specialized center limit access to most people. What research are working on to improve CAR T therapy? Efforts focus on reducing side effects and expanding use of solid tumors, creating off-the-shelf CAR T cells, and combining with other therapies. My methodology. So, my literature researches were conducted by PubMed, Google Scholar, and NIH over a period of study from 2005 to 2025. These are some of my key terms right here. Glioblastoma, standard treatment, CAR T therapy, and CRISPR-Cas9, tumor antigens, all of this. So some of the put together evidence that shows that CAR T cell therapy's efficacy and GBM using different kinds of antigens. Most of my clinical trials were focused on antigens such as EGFR, HER2, and GD2. The goals is to establish CAR T cell therapy. Goals of my research paper was to establish CAR T cell therapy as a widely recognized effective option for GBM. It's also to summarize findings from research papers and clinical trials in a clear and digestible review, and propose future trials on novel antigens and advanced approaches like in vivo CAR T. My results and discussion. So, some of the preliminary findings were the safety and activity trials targeting EGFR, IL-13, RA2, HER2, and GD2 show CAR T is generally safe and active with some tumor regressions or stable disease. There's limited durability. Responses are often short-lived due to antigen escape and tumor heterogeneity and an immunosuppressive microenvironment. The potential for CRISPR-Cas9 may improve CAR T's persistence, safety, and specificity for more durable outcomes. The limitations of CAR T is the small trials and heterogeneity, limited participants, varied targets, and delivery methods hinder comparisons. Most advances remain experimental at the moment, and there's also biological barriers such as BBB limiting T cells trafficking. Tumor suppresses immune activity. There's also publication bias. Positive outcomes are overreported and skewing perceptions. The future directions. In vivo CAR T offers a future path for immunotherapy by avoiding ex vivo cell manufacturing, chemotherapy, improving patient accessibility. Targeted lipid nanoparticles deliver CAR mRNA directed into T cells, enabling rapid in vivo expansion and tumor control in preclinical models. This scalable off-the-shelf strategy could transform cancer and autoimmune therapy by boosting safety, accessibility, and durability. Some of the impacts of in vivo CAR T would be the lower cost compared to regular CAR T. CAR T generated in vivo with lipid nanoparticles would decrease a lot of the costs because regular CAR T cell therapy is very personalized and it has to be different for each individual antigen. It have a greater accessibility because the therapy could be made without specialized labs, and it also reduces the time that it takes, reduces wait times because there's faster treatments. It also has the potential for longer remissions, improve survival, and enhancing quality of life. My conclusion is that glioblastoma is a lethal tumor resistant to standard therapies. CAR T therapy is safe with early activity but lacks durable responses. CRISPR gene editing may boost CAR T's potency by overcoming tumor heterogeneity and immunosuppression, and also increase the persistence. Future trials combining genetic modifications, immune modulation, and precision targeting could mark a new era for GBM treatment and improve the survival. Thank you for your attention. I'd also like to acknowledge all the help that Professor Prahalad and Dr. K. Diaz gave to me during this time. Thank you.
Thank you so much, Shaquille, for that very comprehensive presentation. Let's give Akil a virtual clap. Congratulations. All right. So we'll now proceed with the comments, suggestions, and questions from our panel of experts. We'll start with Professor Prahlad.
Hey, Akil, great job. Congratulations. So, a couple of things here. So, First, you said CAR T cells. So are they in the clinic for glioblastoma already? Do you know what antigens they target?
Yeah, so right now they're targeting a couple of antigens. There are clinical trials, but I think most of them are in phase 1 and some of them are ongoing. The main ones that I said during the presentations are the ones that they're targeting right now. So like GD2, EPH, A2, EGFR, and IL-13 RA2. Those are the main ones that they're doing clinical trials on.
Okay, yeah. So, and you mentioned in vivo CAR T, we had that in the earlier session also, actually.
Yeah,
So, yes, but that's not in the clinic yet, right? Do you
yeah, it's
understand?
purely experimental right now.
Okay. Yeah, all right. Good job, man. Thank you. And good
Thank you.
presentation.
Thanks, Professor. We'll now proceed with Professor K.
Okay, Akil, congratulations, by the way. You're among those who first completed your paper. But how did you manage your time, considering you have limited experience?
I don't know. There were a couple of days that I kind of just stuck to it and like really pushed because it was kind of hard to pay attention because the papers are so long. The research papers they're so long and it takes so much effort. So you just gotta stick to it. Okay.
Okay, I think Dr. Diaz is frozen again, so some connection issue. So,
Yeah, I think your connection
yeah.
is bad because of the
Mm,
weather. Professor K. Oh, okay. All right. Well, thank you so much for the question, and
Okay,
thanks, Akil, for
based on the current
answering the
status
question.
of the research you just discussed with Professor Pollard. Uh, I'm good. I'm good. I'm good.
Okay. We'll get back to Professor K. All right. Yeah. So I'd like to congratulate Akil for a job well done. Your work demonstrated your focus and your intellectual rigor, and um, I know that your research will be groundbreaking. It will have a meaningful impact to uh, the body of knowledge that we have. So thanks, Akil, for that. All
Thank you.
right, let's give Akil a virtual clap again. Okay, so we're moving to the next presenter. Our next presenter is Myra. Myra, are you ready?
All right.
All right, so while waiting for Myra, I would like to remind again our students to post your question here in the chat box. You can do that after the presentation for each student, okay? Myra, can you open your camera?
Yes. Is it the screen sharing?
Yeah, we can see your
Yeah, we can
screen.
see it.
Okay.
Okay. All right. Hi, everyone. My name is Myra Dean, and today my research topic is the therapeutic challenges and the emerging role of immunotherapy in treating primary esophageal malignant melanoma. All right. First off, what is PEMM or primary esophageal malignant melanoma? Well, it is a exceptionally rare and aggressive cancer, accounting for less than 0.1% of esophageal tumors. It arises from melanocytes within the esophageal mucosa, and it is marked by rapid progression, early metastasis, and a poor 5-year survival rate of under 15%. Now, with most cancers, of course, you can, like, the first treatment option is uh, radical surgery to just remove the tumor as a whole. However, there's always a chance that, of course, all of the tumor isn't removed. And since, of course, when you find this tumor, it is already, I guess, too late, because when you start feeling symptoms like general discomfort in the throat or hema, sorry, hematemesis, then that means that the tumor has already become so large and it's basically a malignant tumor that you can't really do much for it. So that's the reason why that's the reason why that immunotherapy is becoming more prevalent in curing most cancers, and now esophageal melanoma. So, and that's the main reason for this study, is comparing the new technology of immunotherapy in treating esophageal melanoma. Okay, so my methodology, I searched databases like PubMed, Google Scholar, SciSpace, and Open Evidence using keywords like PEMM, mucosal melanoma, pathogenesis, biomarkers, and immunotherapy, and PD-1, which is one of the immunotherapy antigens. Mostly English language studies. I say mostly because a lot of the studies, since it's so rare, were actually a lot common in other countries too, like Japan, for example. And I included case reports, series, retrospective and molecular studies, reviews on PMM mucosal melanoma with esophageal prevalence, and excluded cutaneous melanoma only and non-English without translation, and insufficient abstracts. So then, how can immunotherapy be helpful in treating PMM? Well, as I mentioned before, of course, the first option would be radical surgery, which is standard for localized PMME, but long-term survival is rare due to the early recurrence and rapid progression when you first find it. So how the immunotherapy works is mainly with the PD-1 antibody, which here in the figure is showing this orange thing is the tumor cell, and the cytotoxic T cell is the PDL1, which will PD1. No, sorry. So the tumor cell will attach itself to the T cell before it can basically lysis it or attack it and destroy it. So that's where the immunotherapy comes in, and it basically cuts off that tie between them, allowing the T cell to attack the tumor cell to rid the tumor. So immune checkpoint inhibitors have shown better results in PEMM than in other mucosal melanomas, and past patient studies report about a 33% response rate and more than 70% disease control, likely because PEMM tumors have more antigens and CD8 plus T cells, making them more responsive to immunotherapy. This advantage is thought to be linked likely due to more inflamed tumor microenvironment and attracts more CD8 T cells. But overall, PD-1 inhibitors are becoming an important treatment option, though more research is needed to confirm the best way to use them in PEMM patients. So, of course, there are going to be lots of therapeutic challenges and barriers in treating this with immunotherapy. The main one being that since the disease is so rare, there are barely any cases of it. I think there's only 300 that were reported worldwide for this disease. So of course there's limited research to do on it. So, so then managing primary esophageal malignant melanoma is exceptionally difficult due to its rarity, aggressive biology, and the lack of high quality evidence. The disease is characterized by rapid local invasion, early spread through lymphatic and blood vessels, and frequent recurrence even after radical resection. Conventional chemotherapy and radiotherapy have shown little to no benefit, leaving surgery and more recently immunotherapy as the primary options. While immune checkpoint inhibitors, particularly PD-1 blockade, have offered promising responses in select patients, outcomes remain inconsistent and the absence of predictive biomarkers limit patient selection. And as I said before, the rarity of PEMM prevents the conduct of large randomized controlled trials, meaning that most current knowledge comes from the small retrospective series of individual case reports. No major oncology society has issued disease-specific guidelines, so treatment decisions are often based on institutional expertise or extrapolated from cutaneous or other mucosal melanomas. So PMME is a rare, molecular distinct malignant cancer with poor prognosis and limited treatment options. Immunotherapy is emerging as a key modality, but research gaps remain in optimal staging, biomarker identification, and prospective therapeutic evaluation. However, the best option as of right now would be to create um, a global case registry so that every time there is a report of the disease, it can be placed in there so that more extensive research can be done to have more options, of course, since it is so rare. Because, of course, even if a disease is so rare, it doesn't mean that it is significant in the population. So thank you so much. And I'd like to specifically thank Dr. Prahlad and Dr. Cave for this opportunity. And of course, the whole Gifted Gabber team, because I could not have done this without the whole team. And yeah, thank you.
Thanks, Myra, for that graceful and engaging presentation. Let's give Myra a virtual clap. Congratulations. Now it's time to hear the comments and suggestions, or even questions from our panel of experts. We'll first hear from Professor Prahlad.
Hi, Myra. So great job. Congratulations. Good presentation. One small clarification on the thing, the PD-1, PD-L1. So the PD-1, PD-L1 are checkpoint molecules. So cancer cells use PD-L1 to block T cells. They engage with PD-1. So that's the mechanism they hijack. Okay. So just to clarify, and the antibodies block that interaction. And so you talking about melanoma, where the checkpoint inhibitors are pretty successful, right? And but the melanomas here in this case are growing in the esophagus. So how different are they? So did you find any difference? Any literature showing comparing the two from the primary melanoma?
Well, yes, because the skin melanomas, which is of course the regular melanomas that are occurred, they have the same like melanocytes which cause the cancer, of course, but the problem is that they're like completely in a different location. Like they don't usually occur in the esophagus, which is what makes it so rare. So there are, of course, going to be differences since it is in the mucosal layer of the esophagus. So I'm not exactly sure too much on how they are very different from each other, specifically different, but I do know that because of the location difference and the tumor itself, there's going to be differences in how it develops and the tumor itself.
But your study suggests that they are still responsive to checkpoint inhibitors, right?
The checkpoint inhibitors that
Mhm.
are usually used in the melanoma tumors.
Mhm.
Yes. So difference, like they can be treated the same way using those inhibitors in
Mhm.
immunotherapy. But I guess the main difference itself would be that it is in the esophagus.
Okay. Yeah. Good job. Yeah. Congratulations.
Thank you, Professor Prahlad. Now let's hear Professor K's comments or questions. Professor K.
Okay, I'm back. Sorry for that. I missed some, but I followed Mira's progress. It took us a while to choose a topic. We have changed like 4 times, I guess. And then finally, you decided on this topic, despite the fact that you have had difficulty looking for um, literatures because of the limited number of uh, papers that you were able to find. So, um, in what ways did your understanding change from start to finish? I mean, given the limited resources that you've had.
Well, it was very interesting because sometimes I got different results from each location I checked for evidence, of course, of this, because of course, since it was so rare, there was less articles about the tumor itself. I remember going with Dr. Prahlad looking through like PubMed, and there was like barely anything on like clinicaltrials.gov. There was like only one article. So it made it really difficult to find that information that I needed. But I was able, by looking on many different sites, I was able to find like a good amount of information to complete the research.
Had you found this out like way earlier, like would you want to change like your study?
If I like, sorry, could you repeat the question?
I mean, had you like made this decision way earlier, not pressed with time, would you have wanted to change your study?
Um, I don't. I think I probably would stick with the study because I was very interested in it. Because what brought me to learn about this subject was because my grandmother actually had this disease and passed away from it a couple years back, which is why my which is why I've had the big interest in it. So I wanted to really learn more about it.
Okay, and how was the experience and how was your learning helping you cope?
It helped me realize, I guess, why it happened, how it happened specifically. Yeah, sorry.
It's okay. Congratulations, I know it.
Thank you.
Thank you, Professor K, and congratulations again, Myra. Job well done. Okay, now we'll proceed to the next presenter. We have Satvik.
Hi.
Hi. You can now start.
So this is my presentation. The Gene Fix. Can targeting RYR2 and Cas2 gene mutations in CAMK2 proteins using gene therapy treat CPTV? My name is Safik Kaneru. I'm a high school student at Detroit Catholic Central, and I'm a junior. Introduction. What is catecholaminergic polymorphic ventricular tachycardia? CPVT is an inherited genetic disease that is characterized by arrhythmias which lead to dizziness, fainting, lightheadedness, and even sudden cardiac death. It is usually triggered by both physical exertion and strong emotion. It is onset between the ages of 2 to 21, but sometimes symptoms don't manifest until an older age. It is quite rare as it has a 1 in 10,000 incidence, but is extremely deadly, as it has a mortality of up to 50% if, uh, if not treated by age 40. CPVT is classified as a channelopathy, which means it's a gene mutation that is caused by the malfunction of ion channels in the body. In our case, it's the malfunction of the calcium channels and them releasing calcium ions into cardiomyocytes. CPVT has a lot of
Hey,
different
Satvik, just
gene.
a second. Just a sec. Are you have you zoomed in into the thing? Because some of the thing is going off the screen. Yeah, that's better. Or maybe to zoom out a little bit. I don't know why
Mhm. I'm
now
just
it's
in
the
slideshow mode.
one side is going off the screen somehow. Is it only me or everybody? Okay, go ahead, continue.
You might be it if you try to click fit to screen and it might be
Yeah,
better.
that's okay. Go ahead.
Okay. Um, CPVT has a lot of different variants, but this review will concentrate on the two most popular, RYR2 and CASQ2. RYR2, which is also classified as CPVT1, makes up about 70% of cases and is autosomal dominant. CASQ2, which is CPVT2, makes up about 30% of cases and is autosomal recessive. There are other rare variants like COM1, COM2, and COM3, TRDN, and TECRL, but those are so rare that we won't discuss them. The current treatments are beta blockers, flecainide, calcium channel blockers, dantrolene, ICDs, and LCSD surgery, which all have their pros and cons. Even though there are many different treatments, these treatments are not 100% effective, so we need a better solution. A solution that has been proposed is gene therapy. Gene therapy, which includes gene transfer, allele silencing, gene editing, and modulation of signaling pathways, has been tested out in CPVT in both tissue models and mouse models, and hopefully soon human models. My methodology. I included CPVT studies from 2002 to 2025 as it is a very rare disease and there are far and few studies in between. I use databases like PubMed, SciSpace, and Google Scholar to find research papers. I also use key heart journals like AHA journals and Frontiers in Cardiovascular Medicine to complete my search. I searched the databases and journals with terms like CPVT, gene therapy, RYR2, CASQ2, CAMK2, ventricular tachycardia, and medical therapy. I included any studies that had clinical trials, preclinical studies, and gene therapy targeting CAMK2, RYR2, and CASQ2, but excluded any studies on other unrelated genes or non-English articles. My goal was to compare traditional medical therapies with emerging gene approaches to try to find an effective treatment option for patients with CPVT. So, these six are the current treatments for CPVT. As you can see, beta blockers are the mainline treatment for CPVT, but they can fail in up to 30% of patients. In order to cover for this, some patients take flecainide as well, which can stabilize electrical activity, but there's also a chance of making the arrhythmias worse and precipitating even higher and more dangerous CPVT. Calcium channel blockers and dantrolene are very rarely prescribed in CPVT patients as there's limited data of their efficacy and long-term safety. ICD can monitor the heart and sends electrical shocks to correct abnormal rhythms, which are the arrhythmias, in order to prevent triggering of CPVT, but they can also produce harmful electrical storms, which precipitates more arrhythmias and can trigger CPVT. And finally, the only proven surgical option is LCSD surgery or le left cardiac sympathetic denervation, which basically cuts off half of the nerves in the heart in order to stop the release of adrenaline and noradrenaline to stop the arrhythmias from happening in the first place. However, it's very rarely used as there are different patient responses and variable success rates in it. So these are the preclinical studies. There are four main preclinical studies that I went through, and two of them targeted CAMK2, and then the other two targeted the genes. So in the ones with CAMK2, the researchers found a inhibitor called AIP. AIP was extremely powerful in blocking the expression of CAMK2, but only in the blocking of cardiac CAMK2. CAMK2 is used in many different processes, and the ability to only block cardiac CAMK2 was extremely useful. There was also another effect that researchers found was that there needed only to be 50% of the cells to be modified by AIP in order to have complete protection against CPVT, showing a very powerful bystander effect. The middle two studies studied the different types of gene therapy, such as gene transfer, allele silencing, gene editing, and modulation of signaling pathways. These showed how different techniques can be used in mouse models in order to stop the mutations from affecting the patient. Clinical studies. So these clinical studies are show the first patient studies, but they only show flecainide, beta blockers, atropine, and SGT-501. The first two are pretty standard treatments and were done so we can know the long-term effects of safety for both beta blockers and flecainide. The third study, atropine, was a surprise effect. Atropine is not commonly used in CPVT patients, but a test was done where it was determined that atropine could reduce uh, exercise-induced ventricular ectopy in patients with CPVT, but it wasn't good at actually stopping the triggering of CPVT in non-exercise-induced patients. And finally, we have SGT-501. SGT-501 is probably the biggest development in gene therapy for CPVT. It is the first gene therapy that is approved by the FDA to be tested on patients. Testing starts late 2025, and I hope that this development can break open the market for CPVT treatment. So, discussion and conclusion. So, we know that CPVT is caused by mutations in RYR2 and CASQ2 mutations. But the problem is it's really hard to even know that you have CPVT, as CPVT patients have a completely normal heart. There are no structural abnormalities that would indicate anything different. However, if you do an exercise stress test in genetic testing, it shows a doctor that you have CPVT and that you need treatment for it. But because it is very difficult to recognize, lots of patients don't realize that they have it until it's too late. As we saw earlier, the current treatments are good, but not great, and they're incomplete. So we need a more definitive therapy. This is gene therapy. Some challenges of gene therapy are how it can be delivered safely, how to make sure there's no off-target modifications that can change a person, how the cardiomyocytes are going to act to a new gene being replaced. The cost of developing gene therapy is also not to be understated, as developing a gene therapy can take a lot of time and millions of dollars to develop. And because it's so rare, it has a very niche market, making it not cost effective for companies to create one. However, Solid Biosciences has created an AAV-Cas9 therapy, which means that we could have real life gene therapy that can be mass produced for patients. This gene therapy and future ones must be able to prove that they are good in long-term safety and they have the ability to combine with standard therapy to provide full protection. The goal of gene therapy is not only to increase chances of survival, but also increasing restrictions and improving quality of life, as patients can often have very decreased qualities of life. So, I think that gene therapy is going to be one of the best treatments available in any form of disease, but if especially ones in those where it's a genetic disease and the only way to safely and completely treat it is gene therapy. I would like to thank everyone at Gifted Gabber for helping me create a great research paper. Special thanks to Professor Prahlad Parajuli and Professor K. Diaz for supporting me on this journey to write and hopefully publish my first research paper. Any questions?
All right. Thank you so much for that, Satvik. Your arguments were strong, logical, and convincing. Okay, job well done. Now let's hear
Thank you.
the comments and suggestions of Professor Prahlad and Professor K, but we'll start first with Professor Prahlad.
Hey, Satvik, great job. Congratulations.
Thank
So
you.
the question is, it's a genetic disorder, right? But so
Yes.
is it familial? Does it run in family? Do you have any information on that?
Yes. So, CPVT has a 30% familial occurrence because
Hmm.
it needs both, in some cases, it needs both copies from the parents, but in some cases, it only needs one, which gives it around a 30% familial occurrence.
Okay, so it's kind of a co-dominant kind of phenomenon.
Yes.
Okay, so do people go testing then if they have like family history,
Yes. So
gene
if there's
testing?
a family history of CPVT, or even if there's only one case, it is strongly advised to have genetic and exercise stress testing just to rule out, because the earlier that you catch CPVT, the
Hmm.
higher chances of survival you have.
Okay, good job and congratulations.
Thank you.
Thank you, Professor Prahlad. Okay, now let's hear Professor K's comments or questions.
Okay, that Vic and I share similar interest in this study. He was among those who had first, I mean, from the very beginning of the study, he was already keen on this particular study, and we shared this same sentiment. Okay, because it's in the family. Okay, so my question now is, considering the status of this study and the like how much this cost, how do you think will we move forward on making this particular therapy available to third world countries like India, or like developing countries like the Philippines and India?
Um, because Solid Biosciences, I believe, is an Italian company. And patient testing is supposed to undergo late 2025. It said fourth quarter of 2025. So hopefully within the next couple of years, we will get results from that study and hope maybe even future studies as well. And we can see if it's cost effective in order to mass produce these, or is it going to be very expensive, and is it targeted towards rich people, or is it targeted towards everybody?
Nice to know. Thank you for that.
Yeah.
Thank you, Professor K. Let's give Satvik again a virtual clap. Congratulations. So I hope that you will be able to read the whole article very soon. Okay. So thank you. We'll now proceed to our fourth presenter. We have Rishikesh.
Hello, can you see my screen?
Yeah, we can see your
Okay.
screen. Okay.
Hey guys, my name is Rishikesh. Rishi's my nickname, and today I want to talk about neoantigen vaccines. Um, so well, I want to talk about neoantigen vaccines, but on pancreatic cancer, especially PDAC, which is pancreatic ductal adeno adenocarcinoma, which accounts for 95% of pancreatic cancers and remains one of the deadliest diseases. And it's a really fast malignancy. So like it grows worse and worse and worse really fast. And the survival rate of this is under 10%, and it's only 5 years. And diagnosis is often late, and there's really limited treatment options, which are mostly surgery and chemotherapy. A unique and emerging solution for PDAC, I personally think, or I personally like advocate for, is immunotherapy. Because instead of having an external force, it allows us ourselves to activate our immune system and fight pancreatic cancer. An emerging specific type of immunotherapy that is very promising against PDAC are personalized neoantigen vaccines. Um, so the goal of my paper for this literature review is to synthesize studies of these vaccines and really show its effect on PDAC. And coming to why I chose this topic, I have a I'm really interested in immunotherapy and oncology. So study of cancers, study of the immune system. And I'm really interested in vaccines because I don't know, I always like was really fascinated by it as a kid. Because a vaccine was basically the disease, and that was used to cure yourself. And I'm like, oh wow, you were fighting like poison with poison or needles with needles. So I really found that a fascinating part in my end. What are neoantigens? Neoantigens are tumor-specific proteins that can potentially trigger a response in the body. They are found on the surface of tumors they are located in. And as you can see in this picture, this is a normal cell where there's no immune recognition or T cell response. And with the neoantigen, there is an immune recognition, therefore a T cell response. How are these vaccines prepared? First, you have to obtain a patient's sample of the tumor. So collect tumor tissue and match normal sample. And and the purpose of this is to identify somatic mutations unique to the tumor. Number two, you have to produce a list of specific tumors and expression evidence for mutated genes. Number three, predict neoantigens relating to the tumor. And number four, make an appropriate vaccine. So this could be peptide vaccines, mRNA, and dendritic cell vaccines. One question that I had while doing this paper was, aren't the neoantigens in our body? So why do we have to get it out and put it back again? And what I found was our body doesn't really recognize them as much for a tumor or T cell response or immuno response. But once it's, used as a form of a vaccine, like the body kind of sees it as like an external force, and that kind of alerts it to, fight against it. And yeah. The methodology, I use papers from, well, it's a literature review on neoantigen-based personalized vaccines, and I use papers from 2020, I think, to 2024 using PubMed, Web of Science, SciSpace, and clinicaltrials.gov, and ASCO, American Society of Cancer Oncology. And I included studies based on peptide, mRNA vaccines, and then kind of assessed on neoantigen prediction, immune response assessment, and clinical outcomes. I extracted data on vaccine design, immunogenicity, and clinical efficacy, analyzed qualitatively to compare platform safety and clinical benefit. Coming to the results and the discussion of my paper, we could talk about our first paper here. It was based on peptide vaccines. And I think it was I was a couple patients, they were given the vaccines, and it produced good outcomes. There was a mean overall survival of 24 months, and I think the patients took the vaccine and stopped after 8.3 months, and then the cancer didn't occur for 3.1 months. And the immune response was longer correlated, longer survival correlated with higher FNM gamma titers, which are a protein which was related to the immune system, and it was shown in really high levels. And there was an expansion of CD4 plus and CD8 plus effector memory. CD4 it kind of coordinates between the immune system and the disease, and the CD8 is what acts upon the disease. And then patients' vaccine-specific T cell response expanded from 0 to 100%. Some limitations of this paper was that it only had 7 patients, so it was really, really limited. And it wasn't really studied on the long run, right? As you can see, it's like span of 2 years. And there was heterogeneity of prior treatments. So they've had different types of treatments. So we don't know if the cancer vaccine was 100% the the cause for it. And it had a low tumor mutation burden, which mean that it didn't their mutation burden was really low, so they couldn't get much out of it. Neoantigens are really based on high mutation burdens, so it's what they basically get is more information, meaning better results. But this had low information, meaning lower results. And the the technology that predicts neoantigens, it's good, but it's not perfect. So there could be some limitations based on the technology since it's not, to the fullest. And the second type of paper I want to talk about is the mRNA vaccine. This specifically studied the recurrence of PDAC. So people already had surgery, but this study kind of focuses on would they get it again with this vaccine or not. The results, there was oh, by the way, for the paper before, there was not much adverse events, and I'll talk about this later, but I think this is really important. So for all 3 studies, there was really low adverse events, and for this paper specifically, 8 out of 16 patients developed neoantigen specific T cell responses, and the median recurrence, they did not get it for 18 months, and the non-responders did not have a T cell response was 13.4 months. So around 13 months and 6 or 13, yeah, 13.6 months, sorry. mRNA vaccines can induce strong anti-tumor immunity even in immunologically cold tumors. And limitation, again, it was a lot more than the first study, but there was only 16 people, and again, there could be a larger sample size. And this is an early phase trial. I think all 3 are. So again, we need more research, I think, on the long run. And again, for this one, I think there was a lack of a control group for this. And yeah. The third one I want to talk about is the peptide vaccine after chemotherapy. This was well tolerated again, no adverse events. This also had CD8 cells expanding, like having a good response. It was after 3 years, 56% of the people did not get the vaccine or the disease back again. And over the 3 year amount, 74% of the people have lived. Limitations, number of patients are not present. Like I checked the study and it didn't really tell us how many patients there were. So we don't know how reliable it is. So it could be like, if there's not many people, we don't know if, again, we need more people for again, more reliable results. And again, while 56% people got it, like half glass is full, you have 44% of the people that did get the disease back. So again, it's not completely perfect. Coming to the conclusion, I'm personally really, really hopeful about the neoantigen vaccine because it has really low adverse events, meaning it has really low side effects, like something like chemotherapy. Like personally, my grandfather had lung cancer and he did chemotherapy, but it was really taxing on him. Like he was really like emaciated, and it was kind of like I felt really bad for him seeing how his physical like state was. But something like neoantigen vaccines can reduce that. But coming to like the limitations of it, there's not much. It's a really, really new invention. I think it was started around like the 2010s. So there has to be a lot more research done on this, I think personally. And another thing is it's very useful for combining it with other therapies. For example, I think this study right here was combined with a checkpoint inhibitor. And yeah, I think it has really high potential. Um, but there has to be more research on it. And yeah, I think that's pretty much it. I want to give special thanks to Professor Prahalad Barjuli for guiding me through or with lessons on immunotherapy and for helping us choose our topic. Professor K. Diaz for guiding me with creative writing. Professor Virgil Torre Mocha for giving advice for the thesis defense and the submission of our paper. And Gifted Gabber and Coach Show for giving me the opportunity. Thank you so much.
Well done, Rishikesh. All right, let's give Rishikesh a virtual clap. Congratulations. All right. So, the way you presented your paper was, very comprehensive. You combine clarity and enthusiasm in your work. So,
Thank you. Mhm.
I'm really thrilled with the presentation.
Thank you so much. Yeah.
You're welcome. All right. Now let's hear the comments and suggestions from Professor Prahlad.
Hey, Rishikesh. Yeah, wonderful
Uh,
job.
Thank you.
Congratulations.
Thank you so much.
So I have the one comment. I really like the way you explained that, like we have neoantigens, but then we don't normally respond. But if we give it as a vaccine, we respond. Just add to that. I'm adding to that. Okay, explaining because the neoantigens are there, but as I explained to you guys in the class, like immune system responds to danger signals. So our immune system does not see it as danger. That's why it doesn't normally respond. So in the vaccine, we can add components, the danger signals, so that the immune system can now respond to the same antigens, right? So
Yeah.
that's the comment. And now, so you had like two, three different vaccine platforms. Which one do you think is works better? And how would you change the therapy if you had you know, the power and the money and stuff to do it?
Um, I don't think I found much research on this, but I think dendritic cell vaccines have really good potential because it's taking your dendritic cells and taking your cells itself and which are really good for immune response and giving it or making a vaccine based on it. Like it exposes it to neoantigens there, and then I think it makes a vaccine and gets it back into you. So I think that has really good potential. Um, and like the peptide vaccines, I would also say is really good. Because the third study I think I talked about had a
Mm.
74% survival rate. But the mRNA vaccine, on the other hand, I think it only had a 50%. So I think more work has to be done on that. And if I were to control this, or if I were to like try to make this better, again, like I said, I would try to do more and more research, try to make as many or clinical trials as possible because again, this is like a really new invention, so there is limited research, and because it's been really recent. Sorry, like I said, I'm repeating myself. So yeah, that's I would focus on more clinical trials, and yeah, I think that's pretty much it.
Yeah, yeah, and combination therapy.
Yeah,
Hey,
and
great
combination
job.
therapies. Thank you.
Great job.
Thank you, Professor Prahlad. Now let's hear Professor K's questions and comments.
Okay, congratulations, Rishikesh.
Thank you.
Um, Rishikesh, by the way, is also one of those students who finished this paper early. And I now understand why the dedication he has, like, it's pretty much related to his own personal experience, okay, with his grandfather. So now I understand why you really are very much interested in finishing your paper. Now, with that said, I know this is a reach question. Um,
Based on what you've learned so far, which particular combination do you think would you want to recommend that your grandfather would undergo?
Oh, sorry, can you repeat the question again?
Oh, okay.
Sorry,
Um,
the
my connection is poor. So anyway, based on what you learned, perhaps, um, which do you think, which combination do you think would have been suitable, or would you recommend for your grandfather?
for my grandfather. My grandfather had lung cancer, so I don't think I'm not sure. I'm not too sure if I have to look into that if neoantigens are good for lung cancer. But yeah, I would definitely try to cure him first through immunotherapy because again, it's something that happens within. Seeing him in like chemotherapy, it was pretty painful. So yeah, I would try to see if lung cancer is useful for neoantigen vaccines, and based on that, I'll try my best, I guess.
Thank you.
Yeah.
Thank you, Professor K. Let's give again Rishikesh a virtual clap. Congratulations. All right. So I'm happy to hear that you're done with your work. Yeah. So you're just going to refine some sections there. Okay. Rishikesh, you can now stop sharing your screen. Okay. Thank you so much. All right. Now we'll now proceed to our fifth presenter. Um, I'll give the floor to Rohan. Rohan, are you ready? Oh, is Rohan okay? I think Rohan is not around. Okay. Now we'll proceed to Tizia. Tizia, dear. Tizia, can you hear me?
Yeah, sorry. I don't. Okay. Here, let me
Okay.
share my screen.
All right. Go.
Can you see my slideshow?
Yes. Yeah.
Okay, so my topic was neurofibromatosis type 1. Neurofibromatosis types 1 and 2, otherwise known as NF1 and NF2, are genetic conditions that promote the development of tumors on nerve tissue. It does this by disrupting cell growth regulation and leading to uncontrollable cell growth. This is done for mutations in specific genes. NF2 arises in the late teens, but in contrast, NF1 is more common and symptoms arise in early childhood. Both of these conditions can be inherited or come up from spontaneous genetic mutations. Both of these conditions can also lead to many health issues such as tumor development, pain, neurological deficiencies, and problems with vision and hearing. Though neurofibromatosis is a genetic disorder, environmental factors may also impact its severity. According to the Barrow Neurological Institute, a world leading center for neurological research, NF1 can affect anyone, regardless of sex or ethnicity. NF1 is described as a mutation in neurofibromin which leads to RAS pathway dysregulation. The Barrow Neurological Institute informs that NF1 is caused by mutations in the NF1 gene on chromosome 17 that produces neurofibromin proteins. When the mutations disrupt the neurofibromins, which help to regulate the cell growth, it leads to rapid cell growth and tumor formation. The role of neurofibromins is to deactivate the RAS protein when the neurofibromins are being underproduced. The RAS pathway is dysregulated. NF1 can also occur due to mutations in the gene at conception, according to a scientific review written by Monica Goss for the National Library of Medicine. Type 1 neurofibromatosis is inherited in an autosomal dominant manner. This means that there's a 50% chance of the child inheriting it because one parent has the gene. In a journal article written by Andre Lear, It touches on specific pathogen variants in NF1. The GPTase protein that they're talking about in this quote here directly affects the regulation of RAS signaling. This paper also mentions that there are over 2,900 pathogenic variants in the NF1 gene, most of them leading to a lack of full-length neurofibromin protein expression because of gene deletion. This picture is a representation of NF1's interaction with the RAS pathway. In the middle, you can see that because of the loss of NF1 expression, it leads to memory and learning like deficiencies and also cell proliferation. So there are different tumor types that are a result of neurofibromas. One of the tumors among many are gliomas, which are a growth of cells that starts in the brain or spinal cord. Optic gliomas are slow-growing optic tumors that cause worse vision in children and can cause even blindness, and 15% of children with NF1 develop them. MPNSTs, or otherwise known as malignant peripheral nerve sheath tumors, are rare cancers that start in the lining of nerves, and they occur in deep tissue and cause pain. Clinical features that are used to diagnose NF1 are café au lait spots, which are flat, tan to dark brown skin marks that resemble coffee with milk, leash nodules, which are 1 millimeter dome-shaped lesions on the top of the iris, hearing loss, and balance issues. Some of the clinical trials that I researched are listed here. So the first trial was used to evaluate the effect of TQ capsules and find if it can cure the cancerous tumors. The study included 2 phases, dose escalation and cohort expansion. The result from phase 1 of this trial showed that the adult subjects had volume reduction in their tumors. The second clinical trial aims to use R115777 to treat children with neurofibromatosis and plexiform neurofibromas. It blocks the growth of cancer cells by interfering with the function of RAS proteins and other proteins. Participants were randomly assigned this or a placebo drug, and the results were compared. This treatment continues until the tumors remain stable or shrink. Parents and patients kept records of the side effects, and blood samples were also taken to measure the effect on proteins in blood cells. The third clinical trial used sorafenib, which was approved to treat patients with kidney cancer. This trial aims to see if it can also be used to slow the growth of tumors in children with cancer. The trial uses dose escalation to find the highest and safest dose. Patients were monitored with physical examinations, blood and urine tests, MRI scans, and quality of life questionnaires. The results of this trial were not posted. The fourth clinical trial was evaluating how the mitochondria's function changes with time in patients with NF1. So, adults with NF1 had their blood taken for mitochondrial testing, and adults who didn't have NF1 were also had their blood tested, and the patients with NF1 were given questionnaires regarding their pain and fatigue. This literature review aims to review the current treatments used to cure NF1. The study includes other peer-reviewed research papers and scientific studies, as well as clinical trials. The limitations of this study include a wide range of symptoms, small sample sizes, and bias assessments. Because NF1 presents a wide range of symptoms, it would be hard to find general findings across all individuals. And because most sensory assessments rely on reports from parents of the children or clinicians, these assessments introduce bias. In sum, NF1 is caused by mutations affecting the NF1 gene and neurofibromas that help regulate the RAS protein and pathway. It causes uncontrollable cell growth and tumors, which can leave those who suffer with NF1 with long-term discomfort and pain. Most drugs are still investigational, and the research for their treatment is still ongoing. But the first clinical trial that I presented, which was the TQ capsules, showed promising results because the adults with NF1 had like a reduction in tumor volume. I would like to acknowledge Professor Prahalad, Dr. K, and Coach Joe for helping me mentor through this research process. And my experience with Gifted Gabber has been very good, and I've gained a lot of research skills that will help me in the future. Thank you. Any questions?
All right. Thank you so much, Tizia. Let's give her a virtual clap. Congratulations. All right. So your ability to connect theory with real world implications was really excellent, commendable. All right. So let's hear Professor Prahlad.
Natisha, great work. Congratulations.
Thank you.
So, and as I mentioned, I'm also working on this NF1, so it's close to my heart here. Okay. And so most of your research, I don't know if I missed it, were they on like optic gliomas or was it everywhere?
I think it was just like malignant tumors like anywhere. It was just because I think it was hard to narrow down just to people who have optic gliomas because only 15% of people with NF1, I'm pretty sure, develop the optic gliomas. So I'm pretty sure most of the clinical trials did like anybody with a malignant tumor and NF1.
Yeah, so the results that you showed, it worked with some treatment. So was it like for a specific type of glioma, all of them, or they were different, right? So you don't know which site it works better, the treatment works better. Because
Yeah,
it can, yeah. Okay. That's a good presentation and good work. Congratulations.
thank you.
Thank you, Professor Prahlad. Okay, now supposedly Professor K wants to ask some questions, but I think she's having a problem with her internet connection because of the weather. So maybe she will just give you some questions and personal comments via email. Okay? All right.
Okay.
All right. So congratulations once again, Tizia, for the great presentation. All right. Now we're down to our second to the last presenter. So first we'll have Arav, then we'll have Pranav. Okay. So Arav, are you ready?
Yeah, I'm ready. I'm just gonna share my screen.
Okay.
Can you guys see this?
Yeah, we can see your screen.
All right, sorry, let me move this. All right, hello everyone. Thank you for being here. My name is Arav, and I'm going to be presenting my thesis defense on using gut microbiome profiles to predict treatment response in Crohn's disease. So pretty much for this research, I'm just going to explore like how the gut microbiome, which is basically just like the community of like microorganisms in our intestines, could help predict like which treatments will work best for patients with Crohn's disease. Like so basically my goal today is just to explain like why this topic matters, what current studies have been found, and how this research could actually lead to like more personalized treatment strategies for like everybody in the future. Oh, so this is the introduction. I pretty much chose this topic because of my interest in medicine and the personalized therapy. I was actually motivated by like the curiosity about Crohn's disease and like pretty much like I was motivated about Crohn's disease and like the challenges that patients with Crohn's disease go through, such as like myself, and especially like the unpredictability of the treatment outcomes and the side effects that they have to go through. So that's why like my goal was just to explore like how advances in the microbiome science can be applied to the Crohn's disease care for people and how they might actually improve patient outcomes. So for background information, what is Crohn's disease? It's a chronic inflammatory bowel disease, also known as IBD. and it can cause relapsing in inflammation in the GI tract, also known as the gastrointestinal tract. Symptoms for people can actually often include abdominal pain, internal bleeding, like fatigue, weight loss, diarrhea, just like a bunch of side effects altogether. And it actually like affects millions of people worldwide. And like the rates that it's increasing people at is actually increasing by a lot, especially in young adults. So what makes Crohn's especially difficult to treat is that the responses to therapy are like highly variable, because there's not like a singular treatment that can actually work for everybody. Everybody responds to different treatments like very differently. So because of this, like doctors like to use trial and error methods and trial and error prescribing, which actually prolongs suffering and like it increases side effects that people go through, and it adds unnecessary costs, which is like a big problem in our economy. So pretty much this just kind of highlights like the urgent need that we're in like an urgent need for like predictive biomarkers to guide therapy for Crohn's disease. Okay, so literature review and studies. My research was kind of shaped by like a few central questions. The first question was, can baseline microbiome profiles predict treatment outcomes in Crohn's? So actually research shows that patients with higher microbial diversity tend to respond better to biologic therapy, while those with reduced diversity often fail treatment. So that's pretty interesting. Which microbial taxa correlate with biologic therapy response or resistance? So studies consistently show that F. prosnitzii and other short chain fatty acids producers as protective, while pathobions such as E. coli are often actually associated with poorer outcomes. And so the third question is, can interventions such as diet, antibiotics, or FMT improve outcomes? So FMT is actually fecal microbiota transplantation. So clinical trials that I've researched through actually show that diet can enrich beneficial bacteria, and FMT can actually help in some cases, like preventing post-operative relapse, and like antibiotics have been tested to reset dysbiosis through with mixed safety concerns. And another question that I had was, what role do SCFA producing bacteria play in remission? So evidence from these clinical trials actually show that SCFAs like butt irate strengthen the gut barrier, and they actually regulate the immune system, which actually helps explain us why patients with higher levels of these bacteria respond better to treatment. So this is like the past research. These past studies give us like a timeline of this research. For example, like Frank and his colleagues in 2007, they showed that reduced microbial diversity and loss of the F. prosnitzii in Crohn's patients. So actually, F. prosnitzii is actually highly abundant anaerobic and beneficial bacterium that's in the human gut. Sorry, I didn't mention that before. And Anantha Krishnan in 2015 actually found that the microbial patterns were linked to treatment differences. So that just because like people get many different treatments because of the trial and error method, there was such differences shown. Param Soti in 2017 actually showed that the variable results with FMT, or fecal microbiota transplantation, and Sokol in 2020 confirmed that SCFA producing bacteria were actually tied to like a better biologic response after the treatments. And obviously the more recent pilot trials are moving towards something called multi-omics approaches, which combine microbiome, host, and environmental data, which actually could be the most predictive way that we could follow through in the future. So why does this research matter? I think this work actually matters because it connects two important areas in this case, which is the biology of Crohn's disease, and where the microbiome actually plays a central role, and then the clinical need for personalized treatment strategies for Crohn's disease. So like right now, currently, there's like no biomarker reliably predict treatment response, which leads to like a lot of wasted time for people, avoidable side effects, which could actually change like such lifestyle for people, and higher healthcare costs, which is obviously such a big problem in our economy. And by advancing our understanding of the microbiome in Crohn's disease, we might actually be able to guide therapy selection at baseline. So then this builds the foundation for microbiome informed precision medicine, where like the treatments are matched to patients more effectively and more quickly. So this is my methodology. For this research, I actually conducted a narrative literature review of clinical studies and trials. So my approach, So I actually searched through PubMed, Scopus, and Web of Science, and I used keywords such as Crohn's disease, gut microbiome, treatment response, biologics, FMT, which is like I said, fecal microbiota transplantation, dietary therapy, and dietary therapy. So I focused on studies that were mainly published in between 2013 to 2024, but I had the most emphasis I had the emphasis on the most recent work after 2020, and I included the peer-reviewed human studies with and I decided to exclude animal-only studies, and I decided to also exclude unclear methodology and non-empirical studies. So basically, the goals were just to kind of summarize the current evidence connecting the microbiome to treatment response, which would evaluate the predictive and interventional strategies, and that actually highlights the gaps for future research that we're gonna end up doing. For my results and discussion. So I think the findings of this review can be grouped into 3 areas. First is that baseline microbiome diversity often predicts biologic success. So that means like patients with higher diversity are more likely to achieve remission. And then the second is that SCFA producing taxa, especially F. prausnitzii, are strongly linked with remission, while dysbiosis patterns dominated by pathobionts like E. coli are linked with resistance. So when we actually connect the dots, I would say that the microbiome emerges as both a biomarker and a therapeutic target. So dietary changes can actually enrich beneficial bacteria. Fecal microbiota transplantation and antibiotics actually provide more direct interventions, and the composite prediction models that combine microbiome, host genetics, and clinical data are emerging as probably the most promising approach so far. But obviously, with these approaches, we're gonna have limitations. So that actually the studies differ widely in these sampling methods. So and sequencing technologies and the definitions of treatment response. So most are pretty small, single center, and short term, which kind of limits the generalizability for me. And the geographic and dietary differences actually make it hard to compare across populations, because every place, every country has different ways, different foods they eat, which can actually trigger different symptoms for people that have Crohn's disease that actually never popped up for them. And then publication bias actually may exaggerate positive results, and obviously the causality is still uncertain. So the microbial signatures might reflect immune activity rather than the directly drive outcomes. So I think taken together, these studies can actually show that the field is moving from simple associations and instead towards testing causation. So I would say in conclusion, using gut microbiome profiles to predict treatment response in Crohn's disease is actually both plausible and increasingly testable. So I think the next steps, the course of action, would be to include larger standardized multi-center studies and development of composite biomarkers that combine microbiome, genetic, and clinical factors, and testing scalable interventions like diet and microbiome modulation, including alongside with drug therapy. So if this was validated, then I would say these approaches could reduce the trial and error method and the prescribing, and it could shorten the time that people need to reach remission and safety, and also improve the quality of life for Crohn's patients after they have reached the milestone of a remission. So I think this research would represents an important step towards precision and medicine in IBD, or inflammatory bowel disease. Yeah, that's pretty much it. I want to thank Professor Prahlad for providing very great insights into the microbiome and helping me guide my research. I also want to thank Professor KDS for helping me shape the draft and providing helpful feedback. And then I would also like to thank Professor Virgil for giving advice on my research focus and just overall helping me figure out how to present this thesis defense. And also I would like to thank Coach Joe and Gifted Gabber for introducing me to this program and supporting me throughout this process. Thank you.
Thank you so much, Arav. Well done. So your work really reflected originality and boldness, and you weren't afraid to take on a very challenging topic. Okay. So well done, well done. All right, now let's hear some comments and suggestions from our panel of experts. Let's hear Professor Prahlad.
Hey, Arav, great job. Congratulations. So,
Thank you.
you mentioned the diet, right? So, did you find anything like what kind of diet exacerbates the disease?
Yeah, that's actually a good question. So diet is like you never so with like research, like we've never been able to find like what type of diet like may trigger symptoms for Crohn's disease, or like what type of diet specifically like causes what symptoms. But it's always been like IBD or Crohn's is actually like autoimmune disorder. So like it doesn't have a cure, but the thing is that it's always been there. So like some type of specific foods that people eat, like after you have actually figured out that you have Crohn's disease, and like you're going through a flare, meaning like you're having like maybe diarrhea, fatigue, all these different types of problems, internal bleeding. Then there's like different types of foods that can trigger it even more, such as like spicy foods, um
Hmm.
like junk foods, oily foods, fatty foods, stuff like that. But there's nothing like that can actually bring out um the start of Crohn's disease. Like it's very confusing actually.
And what about the relationship with stress? Because stress can cause dysbiosis, cause a kind of autoimmune responses. So,
Yeah, I definitely think
Is
stress
there
is a
any
big thing.
study?
Uh, I didn't research much into it, but I do definitely know that stress does cause problems related to Crohn's disease, because it is located in your intestines. It is located like your stomach. So like people get anxiety, and like people say like, oh, they can feel it in their stomach. So like
Hmm.
stress and anxiety can definitely like cause, it can fasten like it can like fast pace your GI tract and like the whole process. So pretty much through that, it just like it can bring out one of the symptoms of like Crohn's disease.
Well, excellent job. Congratulations once again.
Thank you.
Thank you so much for your inputs, Professor Prahlad. Yeah, I think stress and anxiety can really cause different illnesses. So I hope that you're not all stressed out while doing your research. Okay, well, that's part of the journey.
Yeah.
Yeah. So thank you so much. We would like to hear from Professor K, but I think she will just give her feedback via email. Okay. So we'll move to the last presenter today.
Thank you.
Yeah, so thank you so much once again, Arav. I think our last presenter is ready. Pranav, are you ready?
Yeah.
Okay. Would you like to share your screen?
Yeah.
Okay.
Um, can you see the screen?
Yeah, I can see your screen.
Yeah. Um, Hi, my name is Pranav, and thank you for being here today. My project reviews on chemotherapy associated Charcot-Marie cardiomyopathy, and this is scholarly review. So I'm basically going to talk about how anti-neoplastic agents have induced TCM. And about me, I'm a junior in Farmington High School in Connecticut, and uh, I hope to become a thoracic surgeon one day. I've grown up around medicine with several family members in healthcare, and I've got with my passion in cardiology. I was basically like interested in this topic, and I wanted to connect it with oncology with our cancer research program, so I found this. And for my introduction, TCM is basically a transient syndrome of left ventricular systolic dysfunction that often looks like an acute coronary syndrome (ACS). It has chest pain, ECGs changes, and a small troponin change, but angiography shows no obstructive coronary disease. The classic imaging pattern is normally apical ballooning with basal sparing, which gives the syndrome its name. It was first discovered in Japan in the late 1990s. The classic imaging pattern is apical. Oh yeah, sorry. Um, while TCM is a very rare disease, overall, but cancer patients are overrepresented in some series, with oncology cohorts showing prevalence estimates in the low double digits. It's roughly around in my uh the registry analysis, the registries that I researched showed that it was roughly around 10 to 17% in modern analysis. And distinguishing between true drug-induced TCM from other cardiac events matters clinically because stopping, like for example, you get Takotsubo in a cancer patient, but then it was not actually induced by the cancer drug. No, but then you stop the cancer drug thinking it was induced, and it actually diminishes the person's health because the cancer gets worse. And for pathophysiology, this model and this centers on an acute catecholamine surge. Excess sympathetic activation can produce direct myocyte injury, intracellular calcium overload, and then maladaptive adrenergic signaling, leading to regional myocardial stunning. Then a coronary microvascular dysfunction also likely contributes, and in some cases, it's very rare. Even epicardial spasm was observed. In some cases, it was observed, and age and sex also matters because mostly in Takotsubo occurs in postmenopausal women. So this kind of suggests that hormones and endothelial differences modify susceptibility. And for my literary review, I focused on three literature pieces. First, first the Takotsubo cardiomyopathy in cancer patients by Desai and his colleagues compiled TCM cases in cancer patients and found that cancer is overrepresented in TCM cohorts. They summarized anti-neoplastic agents that induced TCM and outcomes if they survived or not, and also raised concern about worse short-term outcomes in oncology patients. And then secondly, I'm talking about uh, second article that I'm going to be talking about is Takotsubo syndrome in patients receiving chemotherapy drug specific by Medeiros. I think so. That article cautioned that not every Takotsubo cardiomyopathy in a cancer patient is drug specific, like I talked about in the introduction slide, where actually stopping a cancer drug can be deteriorating uh, when it might not be uh, the cause of TCM. The stress of cancer itself can actually provoke similar syndrome since emotional and physical stressors can also induce catecholamine surge. So we should so the article basically says that we should be careful before attributing causality to a single agent. And then my third article is a contemporary update on cancer and Takotsubo syndrome by Tini and his colleagues. This uh, is an updated registry and case data and it also emphasized inconsistent diagnostic completeness across reports Together, these papers show a clear association between cancer care and TCM, but also highlights the limitations in the case literature. And methodologically, this is my article is a secondary literature analysis, a scholarly review, and basically I searched PubMed and Google Scholar and clinicaltrials.gov using terms like Takotsubo, stress cardiomyopathy, agent-specific keywords such as 5-fluorouracil, capecitabine, trastuzumab, and checkpoint inhibitors. I included case reports, case series, and registry analysis, and extracted demographics, timing of exposure, diagnostic tests, management, and outcomes into a standardized spreadsheet. It's a it's a concise table of 40 case reports, and yeah. For my results section, briefly, I'm going to talk about three primary findings that emerged. First, the clinical pattern often mimics acute coronary syndrome, which I already said that in the intro section, and frequently occurs during or shortly after chemotherapy infusions, though timing varies. Secondly, several agents recur in case reports. Fluoropyrimidines like 5-fluorouracil and capecitabine have multiple reports. 5-fluorouracil is like the most popular agent that has induced TCM in multiple cases. Targeted agents such as anti HER2 therapies, some tyrosine kinase inhibitors, VEGF inhibitors, and even immune checkpoint inhibitors appears in case literature. Third, outcomes are usually reversible with supportive cardiac care, and it's not life-threatening usually, but oncology cohorts seem to have worse short-term outcomes than emotionally triggered TCM in non-cancer populations. Few important discussion points follow. Uh, for my implications table, many published reports lack full diagnostic workups such as cardiac MRI or biopsy, which limits causal attribution, so it affects their diagnosis. Clinically, the decision to stop or continue cancer therapy requires weighing cardiac risk against oncologic benefit and often needs a multidisciplinary discussion with cardiology and oncology. Finally, the literature is dominated by case level data. Prospective surveillance and mechanistic studies are needed to define true incidence, identify high risk agents and patients, and guide re-challenge strategies. And to conclude, Takotsubo cardiomyopathy or stress cardiomyopathy is a real reversible cardiomyopathy that can be associated with cancer care. Several chemotherapy agents and targeted agents have been implicated with the strongest case reports for fluoropyrimidines. Uh, Before labeling a drug as the cause, clinicians should definitely pursue a complete diagnostic workup when feasible, using the Mayo Clinic diagnostic criteria. It's a diagnostic criteria that fully lays out what are the clinical presentations of TCM. And finally, management requires balancing cardiac risk and oncologic benefit. And we need prospective studies and better diagnostic reporting to guide decisions, especially about re-challenging therapy. To end this, I would like to thank my creative writing professor, Kay Diaz, for guiding through my writing. And I would also like to thank Professor Prahlad Praluji for mentorship in my cancer research, and my mom who helped me with writing and content guidance. And I would also like to thank Professor Virgil Torimoka for guiding me through the submission process. Yeah.
Congratulations, Pranav. Well done. All right. So, all I can say is that your presentation showed strong analytical skills and creativity. So, great job. Okay, now let's hear some comments and suggestions from our distinguished professors. Let's hear Professor Palad.
Hey, Pranav, excellent job. Congratulations. So now I have the two questions or comments, however you take it. Okay. So one is like, so the drugs, chemotherapy is implicated, but you say that studies show that it's not directly related. But then cancer as well as like cancer related stress and chemotherapy actually increases the stress, right? So that increases the level of catecholamines. And if catecholamines is the cause for the TCM, so has anybody looked at that relationship? Did you find any study?
Um, well, in my research, I just saw a lot of registry analysis showing like they gave a drug like an anti-neoplastic agent, and then TCM occurred right after. So I'm not sure how it affects it yet. Maybe I have to research more about it though.
Yeah, so to just look at that and maybe you can include that in the discussion. If there's no direct relation, there may be an indirect relation via induction of catecholamines. Okay. So now another question is like in your study, did you see that those patients who show like TCM after chemotherapy, are they like worse responders to the treatment or how do they respond to the treatment? Did you see any relationship there?
Wait, what do you mean like are they
How is the prognosis? Yeah, there. So if you look at patients who have TCM after chemotherapy and people who don't, so what is the response compared to the
um
you didn't see any relationship, but maybe you want to look at that because that'd be excellent discussion things there. Okay.
yeah,
Probably because the patients who are like who take more stress, they are worse responders. So you might want to look at that.
yeah.
Okay. Great job, anyways. Congratulations.
Thank you so much, Professor Prahlad, for the insights. All right. So, did I miss anyone? I think everyone already presented, except for those who are absent for today's presentation. Yeah, we're coming to a close and give yourself a virtual clap. Congratulations. Um, you did really well today, and I can see that your presentation are well prepared. They're incredible. You put so much effort in your, in your presentation today, and you did not just only presented strong findings, but also you demonstrated curiosity, your resilience, and your passion. These qualities, will serve you well beyond this program. Closing our presentation today, I'd like to ask our professors, our dear professors, if they would like to, share some few words of encouragement and advice for our students. Professor Prahlad.
Yeah, so I fully second you, Dr. Virgil. So they really need to pat their own back. They have done excellent job, and their thesis is like almost done. So as I always say, now there's a little bit left. The elephant has crossed the line, just the tail is there. So you push the elephant through the finish line, okay? So don't stop here. Let's refine your research and let's publish it, guys. All right? And good luck, everyone.
Thank you, Professor Prahlad. I think Professor K, yeah, has a problem with the connection. So I'd like to, of course, extend our deepest appreciation to Dr. Prahlad, your research professor, and Professor K, the creative writer, for your guidance, for your expertise, and unwavering support in helping our students shape and refine their work. Let's give them a virtual clap. Let's give them the appreciation. Thank you so
It's our
much.
pleasure.
Thank you. And before we end our session today, I'd like to request everyone to open your camera. Let's have a photo op. Okay. All right, Myra. Okay. Okay, at the count of three, show me your best smile. Okay, 1, 2, 3, smile. Perfect. All right. Well, thank you so much,
Right.
everyone, for
Yeah.
joining us today. We'll see you very soon for the one-on-one session. Keep shining. All right.
Yeah. Good luck and good
Thank you
night,
so much.
everybody.
Oh,
Bye.
Thank you.
Thank you.
Have a good
Thank
night.
you.
Thank you.
Bye.
Thank you,
So it
Professor
was,
Prahlad, for your
thank
time.
you. Thank you so much. And yeah, have a good night or maybe good day in Philippines. Yeah, it's a good night for us, late night.
Yeah,
So,
it's already late
okay.
in your time.
It
It's
is, yeah.
actually 10:22 a.m. here.
It's 10:22 p.m. here. So it's, yeah, it's pretty
I'm
late.
back.
Okay.
Sorry.
Oh, that's okay. Yeah. Good to have you back and have a good day.
Yeah, thank you,
Bye.
Yes.
Professor Prahlad.
Thank you,
You're making my job
Thank
really,
you.
really easy.
Yeah. Thanks. And good seeing you guys. Bye. Mhm.
Bye. Ma'am
Grabe.
Kay, thank you so much for the time. I
May,
will just stop recording this.
okay.
I will stop recording this. Um, okay. I think it's on live. I'll just end this, Ma'am Kay, and then we'll just talk in the What's up? Thank you.